And now welcome to our last speaker in this session, Krissie Stiles from Queen Victoria Hospitals, talking about burns management.
Thank you. Good afternoon, everybody. I'm Krissie. I'm the lead nurse for the London South East Burn Network, and I also work as a burn care advisor, which is an educatory service to our non-specialist clinicians who might treat or refer these patients to us. So I've come to talk to you today about the challenges of burn care and the messages that we already heard this morning about the importance of partnerships, the importance of actually making it about the patient and not about, you know, who does what. Sometimes a little bit of the tricks of the trade helps. So there was I in my third year of nurse training as one of the charge nurses from our regional burn service came to deliver a lecture on burns management. I'm sat amongst my peers as the images, very graphic images of severely burned patients flash up on the screen. As the rest of my colleagues start to turn away in disgust and think, I can't watch this, I can't look at this, something clicks in my head and I think, there's nothing that I want to do more than this. This is it. I found me. This is where I want to be. So, what are the challenges of burn care for you? Because I've done this for many years. My background is now burns intensive care unit, where these are the patients that we treat. These patients have no skin. Therefore lies the issue of how do we manage them. Darren's already spoken about the grafting solutions that we have. We use a lot of biosynthetic dressings, dermal substitutes for replacement of skin that patient might not have. The reality is that this patient will come to us with possibly a 50% burn injury, and then we skin graft that area by borrowing skin from the areas that are left unburnt. So something that came as 50% might end up as 80 or 90 or 100% skin loss by the time we're done with them. How do you manage that? And there's a person at the end of this. Yes, burn, it happened to them, it's very unfortunate, it's quite a traumatic injury, but these patients survive. We have 100%ers that go home. We are all very good at doing our job. So the consequences to this patient of survival of this kind of injury, think about that. So it's very quickly becomes less about what we do and about the outcomes of what we do. How does it affect the patient when they go home? How does it affect them year down the line, 10 years down the line? And luckily, there are some things that research tells us already that compromises the outcomes for our patients. So we know that the bigger your total body surface area burnt, the sicker you're going to be. The deeper your burn injury is, the sicker you're going to be. Anatomical location of the burn injury, actually, in this slide, particularly from research, refers to inhalation injury and lung damage, which is one area we can't actually remove, regraft, put back. So it all is down to supportive treatment. But again, think back to that patient who goes home. For patients, the anatomical location of injury that changes their outcome is a burn to the face and a burn to their hands. A lot of evidence now shows that actually the quality of life of our patients is impaired if they have sustained a hand or a face injury. So these are the patients that potentially might try to take their lives. After we've saved their life, they've gone home, we think we've done a really good job, pat ourselves on the back, and then psychologically, and they're not able to function in society, they're not able to do well. So we need to pay attention to these areas specifically. So when you look at criteria for referral, you think, well, do they really want us to refer every single burn on the face and on the tip of the finger? Yes, because we know how it affects our patients in the long run. Age of the patient. Children and adult population do very well. We save their lives, they go home, they get on with their lives. Unfortunately, in elderly trauma in general, not just burn injuries, we cannot do as well as we do in other age groups. So there is still a lot of work to be done to try and manage our geriatric patients with all their comorbidities and the poor healing and tissue viability issues. And of course, if the patient, they don't just come as kind of fit and well, there's always something else that's happened to them. There's always other stuff that's ongoing, their medical issues, the poor circulation, heart disease, all of those sort of things. The radiotherapy patients we've heard about already. So all of these patients then sustain a burn, and that compromises their final outcome as well. So back to the challenges for you, I suppose, when we're talking about the patient has sustained a burn, what is the definition of the burn? Because actually a burn is an umbrella term for so many different etiologies. Most of the burn injuries that we see in the burn service originate from a flame source. And that's in adult males. I'm sorry, boys, you're outnumbered. These are the petrol on the bonfire kind of injuries, yes? So these are the type of patients that I nurse in the general ICU. Scald injuries, as you can imagine, are pediatrics and elderly. Again, a very tricky age group to manage, but those are the two that we see regularly through and through the services. Contact burns, again, happen in elderly patients who collapse against hot surfaces at home and then are not found for days later. The potential for them getting quite sick very quickly is vast. And these are the patients that actually their medical issues might take priority. These are the patients that you, if you're in hospital TVN, might be looking after. Not inside the burn service, inside your wards, in your general hospital, away from plastics. Radiation burns, they're a specialist area, but we see still a lot of sunburn as well. And then electrical and chemical injuries tend to be very, very deep. They tend to be localized by deep and require very specialist management. So when you go to define what is a burn, actually, this is what we're talking about. A burn can be many, many things, and each treatment might be very specific to the type of injury sustained. And then again, in the burn service, we also treat stuff that originates from non-burn skin loss conditions, like your Stephen Johnson's, your TENS, your neck fascias, the scalded skin syndrome. They all have extensive skin loss. They're all very, very sick very quickly, usually as a reaction to a drug or an allergen or a pathogen of some sort. So this is what we're treating and doing donor sites and skin grafts to, and flap surgery. So again, when we're talking about burns units don't just treat burns patients. These are the patients that belong with us as well. But if they're too sick to come to us, you're looking after them as well. So I understand the challenges for you as well. Then Darren already alluded to the fact that when you're assessing the size of the burn injury, there's many methods. So, how big is this burn injury that we're talking about? You could use the London Browder chart, which is the two-dimensional body map that has different values for each part of the body. You could use an app. Mersey Burns app, fantastic app that came from our military colleagues and actually does it just as well too. Our paramedic colleagues pre-hospitally will use the rule of nines, which, as you can see, is a very complicated mass of numbers. And actually, unless you know it off by heart, I really wouldn't go there. So that's why Darren and myself resort to the Palmar Surface area at 2 a.m. This is what I can think of. I can remember this particular chart. It means that patient's palm with the ducted fingers is their 1%. If your palm resembles anywhere near the size of your patient's palm, you can estimate the size of the burn in this way. But the thing is, how accurate is your assessment? Because quite often we come across the question of blister management and burn care. They always get asked this, what do you mean you deroof blisters? Well, you're telling me that you're going to assess the size of the burn injury, yet what you're assessing is the blistered non-viable skin. You have no idea what actually is happening underneath that. We need to remove that dead tissue before you can look at the wound bed itself. There's no point dressing a blister because you're not achieving anything here. So the accuracy of assessment will only be at its peak point if you're willing to deroof and debride the blisters, the non-viable skin. How big is the burn? Because A&E departments refer us a picture on the left. This is the patient from a house fire. He's got a bit of skin loss in his neck and a few blisters on the cheek. When the patient comes to us, something that was referred as 0.5% to the face, I take my dry gauze and start scrubbing. All of it comes off, and underneath this full thickness burn that desperately needs to be grafted. Remember what I said about the patient's faces. How deep is it? If you've not deroofed the blisters, you cannot tell me the depth of the burn injury. There's also the issue of classification. Our American colleagues use first, second, third degree. I have no idea what that means because that's not the classification we use here in UK. We use partial thickness, superficial partial thickness, all of this terminology. Unless you use it every day, really, you're going to get lost in this. So if it's not familiar to you, that terminology gets lost. So actually, Darren already said about the skin layers and how deep we go with donor sites and grafting. Same with the burn injury. What layers of the skin are damaged by the burn? What are the structures that have been affected that might not ever regenerate? And there is this really good saying in burn care, if epidermis is life, then dermis is the quality of life. And that really rings true for our patients. Because for sweat glands not to come back after the burn is damaged through all the layers, for your hair follicles not to come back. Imagine if that burn is just a strip across your scalp and your hair follicles don't regrow. What's the outcome for you as a patient? Small things, something to us as clinicians that might seem, what's the fuss all about? It's a tiny little scratch, it's a small scar, doesn't matter. To that patient, it's everything. It's the end of the world and it really matters to them. So who are we to argue about that? So how deep is the burn? How deep is the burn will guide your assessment, will guide your decisions about management, because reasonably superficial burn will heal by itself within 3 weeks. Minimal scarring, minimal complications. Something that's deeper actually will require a skin graft, will require further surgical intervention to enable it to heal quicker. So we resort to you guys, if you want, pick up the phone and say, Krissie, this patient has no sensation and has poor capillary refill in the wound. I know exactly what you're talking about. I know the depth of the burn that you're looking at without seeing the image of it. Or if you tell me, actually, that I'm poking and prodding it and they're telling me to stop, there's pain stimulus there, great. Nerve endings are intact. Cap refill is brisk, fantastic. This is going to heal well by itself if all the initial measures have been implemented. So how deep is it? This is the answer. Is there sensation? Is there circulation? Simple things done right. And burns are dynamic wounds. You have to question the timing of your assessment. What you see on day 1 is not an accurate representation of where the wound is actually going. The burn wound takes 3 days to demarcate. Depending on what gets done on day 1, and I mean first aid measures, it will then change over time, and it progresses for better or for worse for the first 3 days. So those reviews that certainly our A&E colleagues quite often will bring patients back in 24 hours because they need to have a look at this wound. What for? Still looks just about the same. But the problem is, if those initial measures are not done well on day 1, something that on day 1 looked like a really good wound is going to heal. There was skin loss, but it's pink, there's sensation, there's cap refill. That's great. Why is it that by day 5 you're now reviewing something that's sloughy, necrotic and requires surgery and will end up in a scar and will end up causing contractures if it goes over a joint? So what is the timing of our assessment? Because if this is a delayed presentation, you know that after day 3, this is pretty much, bar infection, this is as good or as bad as it's going to be. So this brings us to the importance of first aid for the burn injuries. We know that 20 minutes of cooling within 3 hours of burn injury is essential for reversing the damage in the wound. I preach this every day when I go to teach my A&E colleagues. Do this, because by the time they come to the burn service, it's too late to do this. We've missed the opportunity. So why is it not done? Typical pediatric scolds are this pull-down injury. Child reaches for a hot cup of tea, brings it down on their face. Child on the left was seen in A&E department, was referred. They didn't do first aid. So we wait to day 3 to decide, do we need to do surgery or will this heal by itself? By day 3, you can see it's a ischemic wound. It's gone white, it's progressed to much deeper layers through the tissues, and now it requires surgery. The problem, especially for girls, babies who've got this pull-down injuries, is scar tissue over a chest area will contract quite rapidly, and if you ever looked after scars and any kind of contractures, it's like a tight rope that sits underneath the tissues. It doesn't expand, doesn't stretch, it's inflexible. When this girl grows to puberty, she won't be able to develop breasts because of the scar tissue that's pulling the skin tight over her chest. These kids who don't remember doing this injury when they're 18 months old keep coming back into adulthood quite regularly to have scar revision surgery done. So our decisions, our points of care at this stage influence our patients decades later. So we've done the assessment. Now, what dressing are we going to put on this patient? This was a house fire patient. Again, all the initial measures were done. We've cleaned the skin. What are we going to put on? What do you have available to you? I outreach a patient like this in our ICU. He was too sick to come to our burns unit, so I go out to him with bags full of dressings. A&E dressed him, bless him. All they had were 5x5 Gelinet squares. Both limbs, torso, circumferentially dressed. I just imagine that healthcare assistant that was standing there open up those packets of dressings as they open up, going, bless them. But that's all they had, and that's perfectly fine. The wound was preserved, they dressed it, it was non-adherent, it worked really well. But ultimately, what do you have? Because I could bring you my store cupboard, but it might not reflect at all what you've got available to you. If it's an agile pediatric patient, quite often they're not ventilated, they're still intent on keeping going and playing and running around. Staying put is the trick of the trade for these dressings, because as soon as you wrap them up, they unpick all your tape and then out the door, and the bandage trails behind them. So very different issues for these patients as well. What about faces? What are we going to do about faces? What dressings are we going to put on the face? Do we even dress faces? Because this is what happens to faces. Initial presentation, and a couple of hours later, this is what happens. The edema sets in. This is a natural progression for a burn injury. Swelling, swelling, swelling. Are you going to accommodate for that when you're bandaging around the face? We already saw Darren's presentation on skin grafts. So this is how we make wounds heal. They're going to have something that looks quite meshed, and the patient's actually going to end up with 2 wounds. Now, Darren said that our Australian colleagues are quite crazy and use Mefix. Well, we use Mefix on my burns unit, and it works a treat. It works really well. I know there isn't any evidence for it, but we use it over our donor sites. And actually, apart from all those fibrous dressings, which our patients found really difficult, you can't shower with it, it gets stuck in the wound, and then it becomes problematic for follow-up care. That was our experience. So we started using Mefix or Hyperfix on the donor sites. It sits like a scab. It looks horrendous, but it dries to a scab, and then as the wound heals underneath, the dressing lifts, and we encourage the patient just to trim the edges until it's fully healed, and then they moisturize, and it works really well. And then when I started looking into it, does anyone else do this? Our pediatric unit actually use Mefix over sunburn in children. So they cover very superficial burn that's not blistered with Mefix, and same principle applies. If it starts to blister underneath and it lifts, it heals really well. Who knew? We also use Aquacel Ag, very differently to how you might use Aquacel Ag. We use it as the only dressing on patients, usually faces. You apply it to a partial thickness wound, so those that have got sensation and got really good capillary refill, dressing adheres, and then we leave it be. It dries to this horrendous crisp, kind of grey, browny scenario, but as it heals again, it peels off, and lovely, healthy skin is underneath. So I'm sure you'd agree this is a really good outcome. And for patients, they're obviously very pleased. Initially, they're quite horrified about how they look. But we pre-warn them. For clinicians, it's the only product. The only product. There's no dressing changes. That's it. That stays on until it comes off and healthy skin healing happens underneath. And finally, the reality of the burn care provision in UK in general is that wherever the patient gets burnt, they're likely to be nowhere near a regional burn service. Wherever you're looking after this patient is likely to be nowhere near a regional burn service. You can see where we all are. There are 4 burn networks, and there's pockets of 4 or 5 burn services within each network. We cover a vast geographical area. Saying that, when I said that in Australia, they all laughed at me in the audience. But yes, for us, the delay in patient presentation to us from A&E setting could be 6 to 12 hours, whereas in Australia it could be 6 to 12 days, and they get flown in. So obviously very different. But the reality of the patient's pathway is that from the time that they get burned, by the time they get to the burn service, they've been through plenty of people who don't usually do burns that now are treating them. I don't know how much stuff you got in your nurse training when you graduated on burns, but we had 2 hours in ours, and I think we were lucky. Most people don't really get an awful lot on burns, yet once you're qualified, you're expected to know all things wounds and treat these patients. So the progression of the patient means that somebody who's not experienced in burn care is treating them. There's less and less of them. Health and safety is great now. We're not seeing these patients come so often, so people who are not experts are treating them. And yet, once they get to the burn speciality, that's when their journey really begins. And it's that post-burn injury aspect of care that actually lasts for 10, 20 years for these patients. So it's the decisions made very early on that impact the rest of their lives. So early contact, speak to us. You have your regional burn service, even though if the patient can't come over to us, you can always pick up the phone and speak. It usually is a nurse-led referral process. So picking up the phone and getting access to that friend who knows how to treat these is the best thing. We also use telemedicine. So picture speaks 1,000 words. We need to move with the technology. This is open to every healthcare professional in the NHS. We use a system that's called TRIPS, and you can log in with your hospital login and access imagery. Take a picture with a digital camera, send to your regional burn service. We can discuss. There are burn care advisors like myself who educate and do events like this. So our job is to raise awareness and support any clinicians who are looking after our patients. We run burns management study days where we bring clinicians into our environment and show them dressing techniques and different aspects of burn care that you might want to know about. And also there is the burns game that's recently been launched in October, which again is something that you can buy for your departments and then play out and learn as to the different types of burns, the initial management, the dressing management, the assessment side of things. So if you're interested, look it up. And at the end of all of this is our patient. What are the outcomes of our decisions? This is William. William had a typical scald, pull-down injury from hot coffee, sustaining injury to his axilla, chest and abdomen. His mum panicked. She didn't do first aid. She put him in the car seat, drove him to A&E. A&E didn't do first aid either. We know it takes 3 days before the burn injury will demarcate because he's not had the appropriate treatment. By day 3, this is what he looked like. So we now know that this wound is on a ticking clock to 3 weeks. If it doesn't heal by 3 weeks, it is going to scar. So with some excision, it's just that area in the axilla, that fatty fold in axilla is not healing, is not budging, and we're already at 2 weeks. Unfortunately, at 28 days later, it's finally showing signs of healing and improving. It's dry, crusty, scabby. It's kind of what we want to see, but it's not healed. And it's only healed at 2 months. We can all heal a wound. And having recently been to India to run a burns course over there, this is what they desire, is to heal a wound and then the patient goes home. As burn specialists, we know that this is the start of the patient's journey because this is what happens later. You get the bunching up of the collagen fibers, the scar tissue develops. This is extremely vascular and extremely itchy. The patient now requires to wear pressure garments for 24 hours a day, removing them 4 times a day to do scar massage and moisturizing of the scar to try and flatten it down. The pressure garments are worn for 2 years continuously. 18 months later, 4 years later, coming back for physio, rehab, scar management. 5 years later, 6 years later, still coming back. He won't remember having done it. He'll always live with the scars that show something has happened. And this is Henry. Henry's mum just made a cup of tea. Henry ran across, pulled it down over himself. She shoved him in the shower. She said, this was a horrible moment. I was watching my baby's skin bubble in front of my eyes. She called paramedics. They called in the shower. They knew they had to do 20 minutes. Within 3 hours, they did that and then drove Henry to A&E department. 3 days later, he looks like William did on day 28. Dry, crusty, healing. 8 days later. 12 days later. Within 3 weeks, he's healed. There's no follow-up, there's no pressure garments, and there's no scar massage. That's a year on from injury. He's doing really well. And that's his only visible scar. And the difference is 20 minutes within 3 hours of burn injury. Every intervention we make is responsible for scars that our patients might wear for the rest of their lives. And you are a big part of this story. You're a big part of their journey. You just need to involve us. If you're managing them, we all need to work together. You're an extended part of the burns team. And what you do makes a really big difference. You just have to decide what difference you want to make.
Thank you, Krissie.
The red light's been on for ages, can I just tell you? I'm just ignoring it.
We are running a little bit over. Does anyone have a quick question for Krissie at all? No? Well, thank you very much to all the speakers.